Yes, we are going very well, very smoothly in the DAMS DVT 2023. Apna time upon khud laega. It is my pleasure to introduce our next faculty, who is a highly accomplished name in the field of medicine. We are honored to have Dr. Arvind Kumar with us, who shall be taking the important topic of medicine Cvs Git. Dr. Arvind Kumar is MBBS from Maulana Azad Medical College, New Delhi. He has done his MD medicine from Lady Hardinge Medical College, New Delhi. He has a vast teaching experience of 20 years. He is a consultant physician at Health First Clinic. Let's welcome the very knowledgeable Dr. Arvind Kumar, who would be taking medicine CVS GIT today. Over to you, sir.
Good afternoon, everyone. All right. So let's start with this session of gastro and cardio revision. Hopefully audio video is clear. So if it is clear, then we can start with the class. All right. So today in this session we will cover high-yielding points of GIT, including the liver and cardiovascular system. So my advice to all of you is that you should study medicine not in very details. So you should have a broad idea and you have to analyze the full picture. Do not go into minute things because that is not necessary at this stage. So let's start with the first slide for today. Okay, tell me, what is this? So let me see who can give me the correct answer for this slide. Yes. All right. Okay. So is audio clear to all of you? Okay. So this is lamp. All right. So if I ask one patient, what is this? Patient will see this part of the lamp and will tell ashtray. Okay. So some are saying yes, it is yellow colored table lamp. But if a patient is saying okay, jaundice. So this is patient missing forest for trees. Means if you have to analyze a situation, so analyze it in a complete picture. Do not let minute details give you the idea and it will be wrong. This minute things is ashtray, this is wrong. So what is this symptom known as of the patient? Patient is missing forest for trees. Patient is just looking at one particular part of the object and giving wrong answers. So yes, very good. This is a case of simultognosia. So therefore in medicine you have to remove that simultognosia. So look at the complete picture. Take only minimal information and make your diagnosis. All right. So patient coming to you with jaundice and SGOT and SGPT are elevated. So all of you have got workbook. So you have to just fill those blanks or fill those boxes which you have got. And PDF will be provided to all of you, but focus in the class. This is revision, everything you have done in your classes. So patient has jaundice, SGOT and SGPT are elevated. These are the liver enzymes. So patient has these features. So patient has look at the first one. Patient had diabetes, pigmentation and pseudo gout, pigmented skin. So this clinical case with jaundice, SGOT, SGPT are elevated. So we will think of the disorder. Yes, we will think of the disorder where there is some iron overload. So percentage transferrin saturation is high and HFE gene mutation is present. So this is sufficient. This is 100% sufficient to make a diagnosis of hemochromatosis. So that means in the minimum information you have made a complete picture. You have analyzed the full situation. So this is expected from you. And the treatment of choice for a case of hemochromatosis, yes, this is bronze diabetes, is phlebotomy. So the treatment is phlebotomy. First clinical case. Now, look at the second one. In the second scenario, patient is young female and patient has recurrent hepatitis. Recurrent hepatitis means patient has jaundice every year. So this disease attack every year. So this is the meaning of recurrent jaundice. So when we will think of such clinical scenario, patient has jaundice every year, young female. So we will think of something autoimmune, and when we did the investigations, ANA positive. So ANA is positive and LSA is also positive. What is LSA? Liver soluble antigen antibody. So liver soluble antigen antibody. So you can see this antibody. This antibody is the most specific antibody of autoimmune hepatitis. Most specific, though sensitivity is very poor, but it is most specific. And biopsy of the liver shows plasma cell. So 100% answer is yes. Very nice. It is autoimmune hepatitis. Autoimmune hepatitis. So this autoimmune hepatitis, this is one of the clinical disease where if you treat the patient in early stage, response is very good. Indeed, whatever field you choose, identify the patient in early stage and this disease will be treated. But if you are not able to identify the disease, if hepatitis progress to cirrhosis, then even liver transplant, even after liver transplant, recurrence chances are there. So very important to diagnose the disease in early stage. If autoimmune hepatitis is diagnosed in an inflammatory stage only, so treatment response is very good, and the treatment is steroids, immunosuppressive agents along with azathioprine. So this has got a excellent response. So this is the second condition, autoimmune hepatitis. Now let's move to third clinical disease. Patient has jaundice and patient has SGOT, SGPT elevated. Now this patient come to us in second decade. So patient is coming in the second decade and patient has neuropsychiatric behavior abnormalities. And when we check the icterus, along with the icterus, KF ring are also seen in the eyes. So that means that we are suspecting a case of Wilson disease. So for the Wilson disease screening test, we will go ceruloplasmin low. And when you diagnose these things, like this child is coming to you and you advise ceruloplasmin and lab report came out to be low, so it gives a kick. Like you are thinking in a right direction. You can be the physician who have diagnosed the patient with Wilson disease. And Wilson disease, though the confirmatory test, gold standard test is liver biopsy. But even before that, you have diagnosed the clinical case of Wilson's disease. Now, treatment. The treatment of this condition is zinc and penicillamine. Zinc and penicillamine will be given. Zinc is the initial drug that we give, but it is a very mild agent. So ultimately we have to shift the patient to penicillamine. That is a copper chelating agent drug for Wilson's disease. Now, coming to the fourth clinical scenario. The fourth clinical scenario is diabetes. Patient had diabetes. Patient has obesity and patient has a black color pigmentation over the back of the neck. So that is known as acanthosis nigricans. So this patient is having metabolic syndrome like obesity, diabetes, insulin resistance is there. So most likely a case of non-alcoholic fatty liver disease. And when we do the gamma GT levels, gamma glutamyl transpeptidase, that came out to be high. So gamma GT is high not only in obstructive disease, it is also high in fatty liver disease. So it is a case of fatty liver with metabolic syndrome. So no doubt non-alcoholic fatty liver disease. So this is a non-alcoholic fatty liver disease. Treatment, of course, we should treat the underlying cause like diabetes, obesity, weight reduction, these things should be done. In parallel with that, vitamin E is a very useful agent. This acts as antioxidant agent and decreases the oxidative injury in the liver. So that is all, you can say, a drug of choice for non-alcoholic fatty liver disease, vitamin E. Yes, correct. Now come to the fifth case. So the fifth is patient has ethanol intake, neuropathy features are present, and on peripheral smear, acanthocyte cells, RBC cells which have irregular spikes, they are seen. So when we look at the simple ratio, we look at the SGOT upon SGPT ratio. So this ratio came out to be more than 2. And this ratio more than 2 is sufficient. No need for any liver biopsy. Is sufficient to make a diagnosis of alcoholic liver disease. So this is sufficient. This information gives you a complete picture of alcoholic liver disease. And for treating alcoholic liver disease, the main is cytokine induced hepatitis is there, TNF alpha mediated hepatitis is there. So we will go for the steroid therapy. So we calculate a score, that is a MADRS score, that will come later on also. So if the MADRS score is more than 32, we start the patient with the steroid therapy. So steroid will be drug of choice. So now you can see there are 2 hepatitis where steroid are given, autoimmune hepatitis and alcoholic liver disease hepatitis, alcoholic liver disease. Vitamin E in diabetes. Vitamin E in diabetes is to be avoided. If diabetes is under control, then you can give, but otherwise long-term use of E is not recommended in diabetes. Yes. What is GGT? Gamma glutamyl transferase or transpeptidase. Now, coming to the next group of disease in which patient has jaundice. Along with the jaundice, patient has pruritus and pale stools. So if patient has pruritus and pale stools, that means it is a case of obstructive jaundice. That is a case of obstructive jaundice. So this patient comes to you, ALP and gamma GT, they are elevated. They are elevated. So our next step will be, we should go for non-invasive test. So as a physician, you are suspecting that a patient has obstructive jaundice features. So just go for the ultrasound, and in the ultrasound, focus on common bile duct. Focus on the common bile duct. If common bile duct is not dilated, it is not dilated, it means obstruction is intrahepatic bile duct obstruction. While if patient has dilated common bile duct, so it means it is a case of extrahepatic obstruction, extrahepatic bile duct obstruction. So we can differentiate these two conditions, because extrahepatic are mainly surgical causes like CA, head of pancreas, and intrahepatic is they are medical causes. They are medical causes. So there are two conditions. There are two conditions where intrahepatic obstruction occur. Patient present with obstructive feature. One is primary biliary cholangitis, and second is primary sclerosing cholangitis. So to differentiate them, our next step will be antibodies. So we will go for anti-mitochondrial antibody, AMA. So AMA is positive. So look here, this disease is more common in females, and there is associated Sjogren syndrome, very commonly associated extrahepatic manifestation, and AMA antibody are positive. Obviously, this will become a case of primary biliary cholangitis. PBC is primary biliary cholangitis. While the disorder which is more common in males, ulcerative colitis history is present. It means it is a case where ANCA antibodies are positive, p-ANCA antibodies will be positive. So this is seen in primary sclerosing cholangitis. So this is a case of a sclerosing cholangitis. So these two conditions we can differentiate not only on the basis of the antibody but clinical features also. Now moving on to the acute viral hepatitis cases. So acute viral hepatitis, whenever patient comes, so you have to first look at what is the mode of transmission. Sometime mode of transmission will give you a correct answer. So keep the thing very simple, very basics, and you will get your answers. So there are two types of mode of transmission. One is a fecal-oral mode of transmission, in which exposure history will be given. Exposure history like outdoor picnic, patient has taken food or water from outside, and after 4 to 6 weeks patient developed jaundice. So after incubation period of 4 to 6 weeks. So these are fecal-oral virus. So there are two fecal-oral virus, that is A and E. While when there is no fecal-oral method, it could be a blood transfusion, percutaneous or needle stick injury. So those are B, C and D. These will be the virus, and you need some additional information. First is the mode of transmission. Second is the additional information. Additional information can be the geography. Geography means the age of onset for that particular virus. Some viruses are common in children, some are common in adults, or it could be some clinical feature associated with that viral hepatitis, and ultimately in the last is the serology of the viral hepatitis that will almost confirm the diagnosis. So let's see how we will approach the cases. So fecal-oral mode of transmission is present. So child age group is given, like a school bus or a school class went for a outdoor picnic. So most common acute viral hepatitis in children. Second feature, within acute phase there are two episodes of jaundice. Hepatitis jaundice relapse within acute phase, 2 times jaundice attack come. So this is a classical feature of, yes, very nice, this is a classical feature of hepatitis A. Hepatitis A will be the answer here. While most common cause of acute viral hepatitis in adults or maybe in pregnancy, and patient has cholestatic features. So this is a case of hepatitis E. So even without looking at the serology, you are making a diagnosis. So without looking at the investigation, if you are making a diagnosis, that means you are a very good doctor who is identifying the disease without the help of investigations. Now the second one is non-fecal-oral group. So let's come to the non-fecal-oral group. So in the non-fecal-oral group, it could be a percutaneous mode of transmission or a vertical mode of transmission. So the first clinical scenario, it is the most common cause of viral hepatitis in the world. Only viral hepatitis is being mentioned. Acute chronic is not written. And it is the most common cause of hepatocellular cancer. Patient has joint pains, rashes. Joint pain and rashes is the classical feature. It is indicative of serum sickness. So this is a serum sickness. This is a case of hepatitis B. We should be so confident that without looking at the serology, we will mark the correct answer that it is a hepatitis B scenario. While the next one, most of the patient are asymptomatic. Most of the patients are asymptomatic in the acute phase, and this is the most common viral cause of the cirrhosis. So this is a case of C, hepatitis C. Patient first time comes with hepatitis C only because of cirrhosis. While maximum risk of fulminant hepatitis, patient come with fulminant hepatitis. So the risk is maximum when there are 2 viruses in the body. So 2 viruses means hepatitis D is the answer, because hepatitis D always come with hepatitis B. So there are two viruses in the body. They are damaging the liver more. So two virus damage the liver more. So this is a case of maximum risk of fulminant hepatitis is hepatitis D. Now, let me ask you one question. So you can write that question here. Space is given for you to write the question. So let me see who will give me the correct answer first. Listen to the question very carefully. In the exam, read the question very carefully. All right. So most common cause of SCC overall, is hepatitis B only. It is hepatitis B only. All right. So tell me the answer. My question is, most common cause of fulminant hepatitis. Your answer. So that question you can write here in these blanks. I will again repeat my question. My question is, most common cause of fulminant hepatitis. Yes, chat box is running. B, C, D, E, B, C, D, E. All right. So some of the students have given me the correct answer. So the correct answer here is paracetamol toxicity, because I have asked the question as most common cause of fulminant hepatitis. I have not asked viral cause. So most common cause of fulminant hepatitis is paracetamol toxicity, PCM toxicity. Yes. Now moving to the next one. So if the viral cause is given, maximum risk is with the hepatitis D, especially with the super infection, Yes. Now moving to this aspect, serology of the viral hepatitis. Now ready with your answer. So serology is one of the topic where one question is guaranteed in your exam. So the first one is, yes, IgM anti-HAV. The answer is similar. Acute hepatitis A. Very simple answer. Number 2, IgM anti-HBC plus HBs antigen is given to you. So take the minimum information and make your diagnosis 100% correct. So if the second was the serology, answer here is acute hepatitis B. Third answer is IgG anti-HBC along with HBs antigen is given. So wherever IgG word is written, so that means it is more than 6 months, and for more than 6 months HBs antigen is present, virus is present for more than 6 months. So it is a case of chronic hepatitis B. Yes, it is chronic hepatitis B. Now let me see who will give me the fourth answer. Yes, I am waiting for the fourth answer. HBV DNA is high and SCV RNA HBe antigen negative. So the fourth one, let me see who give me the correct answer for fourth one. Fourth one is DNA is high and HBe antigen is negative. Okay, all right, great. So this is a case of a pre-core mutant. Yes, most of you are correct. This is a case of a pre-core mutant. Whenever E antigen is negative but DNA levels are high, so it is pre-core mutant. Pre-core mutant means they are not able to make E antigen. While case of IgM anti-SCV and SCV RNA is positive. Acute hepatitis C. So this is a case of acute hepatitis C. While IgG anti-SCV is present with SCV RNA, obviously this is a case of chronic hepatitis C. Now, additionally, What about this one? IgM anti-HDV is present, IgM anti-HDV, while IgM anti-HBC is present. So this is suggestive of which infection? Which infection? Yes, IgM anti-HDV and IgM anti-HBC. So this is suggestive of, yes, very good. This will be a case of co-infection. This is a co-infection of hepatitis D with hepatitis B. Co-infection, because both are coming at the same time, both are coming into the body at the same time, so both are acute, both are IgM positive, yes, this is co-infection. While IgM anti-HDV is there and IgG anti-HBC is present, IgG is present. So this scenario is chronic hepatitis B was already present, and on that D came. So this is a case of superinfection. So this is a case of superinfection of hepatitis D on hepatitis B, on the hepatitis B, superinfection. So this is a summary of the commonly asked serology from you, commonly asked serologies. Now coming to the next one. So next one are liver scoring systems. So they ask you ki which score is used in which disease. Fulminant most common with superinfection. As I told you earlier, fulminant hepatitis more common with superinfection. What is window period? Window period is IgM anti-HBC positive, S antigen negative, it's antibody negative. Only IgM anti-HBC is positive. Now coming to the liver scores. So the liver score, these are the important liver scoring. So they ask you ki where is that liver score used and what are the parameter used in a particular liver scoring. So the first liver score, if you see here, so the first is Madray score. So Madray score is the score which is used for alcoholic liver disease. So in alcoholic liver disease, in some of the previous slide we have seen treatment is steroids. So but when to give steroid? When the Madray score is more than 32. So the parameter used are bilirubin and prothrombin time. This is a formula. They might ask you the scoring, how much score has been there. So you have to calculate that score. Madray score 4.6, prothrombin time of the patient minus prothrombin time of control plus serum bilirubin. So this you have to calculate on your own. If this score is more than 32, indication for steroids. Steroids should be started. All right. Now come to the next one. So in the next one, Wilson disease is given. So this is a scoring system which is used to determine the severity of Wilson disease, and three parameters used are bilirubin, prothrombin time, SGOT. And take it as a hint in your exam for MCQ purpose, two parameters are used for every liver scoring. These two parameters are bilirubin levels and prothrombin time, or maybe INR. So your options will be ruled out. So every liver score consists of at least these two parameters, bilirubin and prothrombin time. So here SGOT is additionally taken. So this is a case of Nazar. Nazar score is used for the Wilson disease. Now MELD score, model for end stage liver disease. So this is used for liver transplantation indication. Now according to what are the options given to you, you have to change your answers. So classically MELD score consists of three parameters classically. So look at what is the question being given. So these classical are given in the above, that is bilirubin, INR and creatinine. So bilirubin, INR, creatinine. These are classical for MELD score. But for a modified MELD score, two additional markers are also used. So that depend on what is the question set by the examiner. So examiner might give you sodium and albumin. So these are the two additional parameter for a modified MELD score. So if they are given in the option and the option is all the above, so mark all the above. While if these classical are given and fourth option is irrelevant, all except, so mark that irrelevant option. So depending on the what is the question being given, you have to modify your answer. So in your exams, this is for classical MELD score and two parameters for modified also, for the modified. Yes. Now Lilly score is steroid response at 1 week. So in alcoholic liver disease. So in that we take A, B, C. So A, B, C is age, albumin is A, B is bilirubin, and C is creatinine. And of course prothrombin time is used for every scoring system. So that is taken for the Lilly score. Steroid response at 1 week of steroid therapy. While child Pukes score, so the child Pukes score is for cirrhosis severity, in which 3 biochemical parameters are taken and 2 clinical parameters are taken. Clinical are ascites and encephalopathy, while 3 biochemical parameters are same, bilirubin and prothrombin time, used in every scoring system. So we use bilirubin and prothrombin time, and the third parameter is albumin. So this is the parameter used for child Pukes score. Now coming to the complications of liver disease. So the complications of the liver disease are ascites, and one of the important complication of ascites is spontaneous bacterial peritonitis. So patient of ascites come to us. So the patient of ascites, how to manage, especially if it is due to cirrhosis. So what we have to see, most importantly, we have to see the clinical signs of ascites. Two important clinical signs: fluid thrill and shifting dullness. So these are the two important signs. Suppose these signs are negative, they are not present. It is only on ultrasound that the fluid was diagnosed on the ultrasound. So if only ultrasound shows fluid while clinical signs are absent, our next step will be, we will go for salt restriction. Diuretics are not needed here, so no role of diuretic here. So we go for salt restriction. In that scenario, with salt restriction, ascites will improve. Now the second one is, if clinical signs are positive, respiratory distress. So we will look at the respiratory distress. So if the respiratory distress is absent or present, that will decide further course of action, because ascites fluid can be so massive that it compress the diaphragm into the lungs and patient can be dyspneic. That is known as respiratory distress. But if that scenario has not yet occurred, respiratory distress is absent but patient has shifting dullness, so we will go for diuretics. Diuretic of choice, we use two diuretic. One is the diuretic which is against the aldosterone, and second is a highly effective diuretic. So we give a patient spironolactone and furosemide. So these are the two diuretics which are given here. And if after giving the furosemide and spironolactone there is no response, ascites is not improving even after 1 week. So no response even after 1 week of maximum doses of the diuretics. maximum dose of the diuretic, spironolactone 400 per day, milligram per day, and furosemide is 160 milligram per day. So if there is no response with these agent, that is known as refractory ascites. So what should be our next step? If it is a case of a refractory ascites, we will go for large volume paracentesis along with the albumin. Yes. And if ascites fluid is causing significant respiratory distress, we will go for straight away large volume paracentesis and albumin. So this is how to treat a case of ascites which is induced by cirrhosis. This is uncomplicated ascites. While if there is a complicated ascites, so the complicated ascites is spontaneous bacterial peritonitis. That is complicated. Complicated means ki infection has started in that ascites. So, but how we will recognize that patient has SBP? With the help of some clinical features, with the help of some investigations. So, clinical features, patient will have fever. So albumin, how much? Albumin will be 6 to 8 grams per liter of fluid drained. Maximum doses are 400 milligram per day of spironolactone and 160 milligram of furosemide per day are the maximum doses. Okay, previous slide. This is the previous slide. All right. So patient has spontaneous bacterial peritonitis. We will recognize it clinically. Patient will give history of fever. Patient has cirrhosis on the background, and patient without any intervention, without any surgical process, has developed spontaneous infection of peritoneum. So fever will be there and patient will complain of abdominal distension. Now, this spontaneous bacterial peritonitis, it develops on the background of cirrhosis. And in cirrhosis, proteins are very low in the peritoneum, antibodies are very low in the peritoneum. So, inflammation in the peritoneum is low. So, the classical sign of peritonitis, which is rebound tenderness, is absent. So, this is a paradox. Even though it is peritonitis, but rebound tenderness will be negative or absent. Reason being, peritoneal inflammation is very minimal here because proteins are less, local antibodies are less here. Less here. Now, what is the ascites fluid will tell us? So, ascites fluid, serum, albumin, ascites gradient. This is known as SAAG, serum albumin ascites gradient. This will be like a cirrhosis. This will be exactly like a cirrhosis, so it will be more than 1.1 because this is cirrhosis induced. Neutrophil is the defining feature. Neutrophil count here will be more than 250 mm3. While proteins, so proteins will be less than 1 gram per day because it is cirrhosis induced. So the proteins are less in the peritoneal fluid. And if the proteins are less, this makes the patient at high risk of recurrence. So this SBP will recur again and again if the proteins are less. Protein are less means local antibodies are less. So that will predispose to frequent recurrent infections. While culture. So the culture, when we'll see, we will see the most common bacteria here, and the most common bacteria for cirrhosis induced SBP is E. coli. Cirrhosis induced SBP is E. coli. And the drug of choice here is cefotaxime. So DOC is cefotaxime. SAAG long form is serum ascites albumin gradient, that is serum albumin minus ascites albumin. So it is more than 1.1. Now coming to the intestinal part. So this was about the liver section, and some of you were asking the question ki what is the serology of hepatitis B post vaccination. So the answer is very simple. Serology of after post vaccination hepatitis B is anti-HBs antibody, no other marker, only anti-HBs will be the answer. Now furosemide and spironolactone given together, yes, they can be given together. Now malabsorption syndromes. So the malabsorption syndromes, the most common abnormality is fat malabsorption, and that is present in every patient of malabsorption syndrome. So malabsorption syndrome is, first we go for D-xylose test. So the D-xylose test is suggestive of proximal small intestinal involvement. So D-xylose test is abnormal. Then we look at the Schilling test. Schilling test is suggestive of distal small intestinal involvement. So the combination here are patient has D-xylose abnormality, means proximal small intestine is affected. Schilling test is normal, that means distal is spared. So there is one disease which affect the proximal part of the small intestine. Clinical features are given as dermatitis herpetiformis. Investigation to help you is anti-TTG antibody. So 100% answer here will be celiac sprue. No other answer. Celiac sprue affect the proximal small intestine. While the second one, the D-xylose test is abnormal, proximal small intestine affected. D-xylose is also abnormal, distal intestine is also affected. So we have to think of a disease which affect both the proximal part as well as the distal part. Both the parts are affected. And clinical hints are patient has migratory arthritis, patient has pass positive macrophage on the biopsy. So these are sufficient to make the answer as Whipple disease. So this is a case of Whipple's disease. While the third one, is D-xylose test is normal, means proximal small intestine is normal, Schilling test is normal, so small intestine is not affected, and patient has pruritus and ALP levels are high. So what does that mean? That means it is a case of bile duct obstruction. So in bile duct obstruction, bile is important for fat absorption. So bile is not going to the intestine. So because of that process, there is steatorrhea or there is fat malabsorption. So, but without involvement of small intestine. So this is a case of bile duct obstruction. Yes, obstructive jaundice. While in the last scenario is patient has a D-xylose test normal, but Schilling test is abnormal. Schilling test is coming out to be abnormal. And the hints given to you are hyperpigmented knuckles. So hyperpigmented knuckles are suggestive of, are due to B12 deficiency, and which occur when the distal part of the small intestine is more severely affected. Answer? Yes, very good. It is a case of tropical sprue. So this is how we can make a diagnosis with the information available to us. Yes. Yes, it can be ileal disease resection or Crohn's disease which is affecting the ileum. So I have taken one example, tropical sprue. Why not bacterial overgrowth syndrome? Because bacterial overgrowth syndrome will be here. But look at the clinical feature. Clinical features are migratory arthritis and pass positive macrophage. So these features are not seen in BOGS. So you have to gather the information, clinical information, and then make the correct diagnosis. All right. Now, the next one, Intestinal disease, irritable bowel syndrome. Main cause is stress induced altered bowel habits. So this irritable bowel syndrome is defined by a criteria, so because they will give you a clinical vignette, so you have to choose the points from the clinical vignette to make the definition of IBS, that is irritable bowel syndrome. So irritable bowel syndrome, the criteria is which is used is the Rome 4 criteria. Rome 4 criteria is used here, and Rome 4 criteria is essential criteria. Abdominal pain should be there. There should be abdominal pain for 1 day per week, and the frequency of that should be present for more than 3 months. So it should be for more than 3 months. While symptom onset, total symptom onset should be of more than 6 months. Understand this point clearly. Total duration of the IBS is 6 months. Total duration. But this particular frequency, which you can see here, this particular frequency should be present for 3 months at least. Should be present for 3 months. While pain should increase by defecation. There should be a change in the stool frequency. There will be a change in stool consistency. So any two of the three features will make it IBS. Now, the clinical feature which are not seen, so they will exclude the diagnosis of IBS. Never ever weight loss is present, though the duration will be chronic, but no weight loss. It is a functional disorder. Blood in the stool, not present. While nocturnal diarrhea. Nocturnal diarrhea is patient has to wake up in the night to pass a stool. Not present. Where is the nocturnal diarrhea present? Nocturnal diarrhea is whatever patient eat food during the day, that food reaches the rectum, inflamed rectum during the night time. So that will irritate the rectum. Urge for defecation will occur. Answer, ulcerative colitis. So this nocturnal diarrhea is a feature of ulcerative colitis, never seen in irritable bowel syndrome. So pain is relieved. No, pain is associated. Pain is increased by defecation. This is a Rome 4 criteria. That was a Rome 2 criteria earlier, where it was written pain decrease on defecation. But now it is increase on defecation. Now there are two important miscellaneous topics. So identify these topics. Why these topics are asked? Because they are more common in the community. So if question is most common nosocomial diarrhea. So most common nosocomial diarrhea is Clostridium difficile. Most common nosocomial diarrhea, Clostridium difficile. So therefore they ask the question from most common topics. Most common topics. Then most common antibiotic associated with Clostridium difficile is cephalosporin. It is cephalosporin because it is used very frequently. While diagnostic criteria, there should be clinical plus investigation. Clinical criteria of loose stools 3 times in a day, and they will be present for more than 2 days. Minimum criteria. And investigation should be positive for Clostridium difficile. So the investigations are toxin detection by PCR method, culture positive, or pseudomembrane on colonoscopy. Any 3 of these. So toxins by PCR method, culture, or pseudomembranous enterocolitis. So this is diagnostic for the Clostridium difficile infection. These are the diagnostic criteria for Clostridium difficile. Now the drug of choice, these days the drug of choice is not metronidazole, it is not vancomycin. So this is the drug of choice. Very good. But there is one scenario in which we do not use the drug of choice. We use vancomycin and metronidazole, and that condition is a fulminant disease. Now understand this, in a clinical vignette you should look for the signs of fulminant disease. Signs of the fulminant disease will be TLC count will be more than 15,000 and serum creatinine will be more than 1.5. Along with that, if patient has evidence of sepsis or toxic megacolon, this is fulminant disease. If patient has these features, here we give vancomycin, never intravenous vancomycin. So examiner might give you IV vancomycin in the option, but that is not the correct answer. Vancomycin is given orally and per rectal, and IV which is given metronidazole. Here we use these two agents. So we will use vancomycin. So vancomycin, the mode of or route of administration is oral and enema, that is per rectal preparation. Along with that, intravenous metronidazole should be given. While if a patient has got recurrent disease, so patient has recurrent disease, so in that we will give antibody against the Clostridium difficile toxin. So antibody will be given. So that antibody is to be given. Indication is, this is the antibody against the toxin. Indication is a recurrent disease, not as a first line, but as a recurrent disease. Now, identify this infection. This infection is decreasing the risk of, surprisingly, it decreases the risk of GERD, gastroesophageal reflux disease, esophagitis. It decreases the risk of esophagitis. It decreases the Crohn's disease risk. Childhood asthma risk is also reduced. So this is the classical infection of H. pylori. Yes, this is H. pylori. Okay, previous slide. Okay, H. pylori is the infection. Now for diagnosis of the H. pylori, most sensitive investigation is we do a biopsy and we do the urease test in the biopsy. So that is known as a biopsy urease test, very sensitive. While the most specific investigation is the culture. There is no other cause. So we go for the culture. When to give the antibody against the toxin, that is when there are multiple recurrence of the Clostridium difficile infection, recurrent disease. Now, non-invasive test is breath urea test, while the test for treatment follow-up is also breath urea test. So these are the two answers. Indeed, this was the inicet last year exam question also, which is the investigation for follow-up of H. pylori infection after treatment has started. So it is breath urea test. While in the management, we gave 4 drug combinations. So the indication of treating H. pylori are only 2 main indication. First, peptic ulcer should be present, and second, lymphoma should be present. Malt lymphoma, mucosa associated T cell lymphomas. So these are the 2 indication where we give 4 drugs. O, omeprazole, B, bismuth, M, metronidazole, T, tetracycline for 2 weeks. So this is the treatment which is given for the treatment. Now, coming to the cardiology. So in the cardiology, we start with the outermost layer. So these are the important questions on the pericardial disease. So important questions on the pericardial disease is patient has chest pain, that is a pleuritic chest pain, very sharp chest pain. Patient has on auscultation crepitations from pericardium, known as pericardial rub. On the ECG, PR segment depression and ST segment is elevated, just like this. So you can see here, this is the PR segment and this one is a baseline. So from the baseline, PR segment is going down, PR depression, and ST elevation is there, which is concave upward ST elevation. So this combination is a classical case of acute pericarditis. Yes, this is a case of acute pericarditis. Treatment is anti-inflammatory agents, and these anti-inflammatory agents are combination of aspirin. Aspirin will be in anti-inflammatory dose, high dose anti-inflammatory dose, and ibuprofen. So this is to be given. Yes, NSAIDs, anti-inflammatory agents, are given here. So this is the first case, pericardial disease. Now identify the second one. Patient has dyspnea, backstride is present, absent white descent in the JVP, and when we do the ECG, so this is the ECG which is present. So in this ECG, what exactly is happening? First QRS amplitude is slightly more, the second QRS amplitude is less, then high amplitude QRS, then low amplitude QRS. So the QRS amplitude are changing here alternatively. They are changing alternatively. So this is a classical case of electric alternance. So this is electrical alternance on the ECG. Yes, very nice. So this is a case of pericardial tamponade. So answer is tamponade. The treatment of the tamponade is you have to remove the fluid from the pericardium immediately under echo guidance. So we go for a echo guided pericardiocentesis. And remember this point, electric alternance is totally different from pulsus alternance. They are very two different things, different findings and different causes. Pulsus alternance is seen in left ventricle failure and electric alternance is seen in pericardial effusion, or you can say tamponade or the tamponade. So this is a case of a pericardial tamponade. Now look here, patient has swelling, and very important keyword, pericardial knock. So there is only one answer whenever pericardial knock is there. And on the ECG, if you can see, there will be low voltages. How we know that low voltages are there? So look at the standardization in the ECG leads. This is a box which is 10 mm in height. So they, normally the lead to QRS complex are 10 mm. They are normally 10 mm. That is a normal voltage. But if you compare this box, this is a standardization box, you see the QRS complex. These QRS all complexes are very small as compared with this standard height. Normally they are equal to the standard height in lead 2. So they are low voltage because calcification of the pericardium decreases the current transmission outside. So the ECG complex will be low voltage complex. So clear cut, this is a case of constrictive pericarditis. So diagnosis CP, constrictive pericarditis, and the treatment of this condition is a surgical condition, that is pericardectomy. So remove the pericardial layer, patient will improve. Patient will improve. All right. So moving on to the next one, hypertension. So hypertension, so many guidelines are there. So I have taken only the International Society of Hypertension guidelines, which AHA also follows. AHA also follows. So if hypertension is grade 1, so grade 1 hypertension means systolic BP is 140 to 159 and or diastolic BP 90 to 99. So in that condition, we will look at the comorbid conditions like coronary artery disease, diabetes, CKD, or hypertension mediated organ damage like LVH on the ECG, LVH on echo. So heart is affected due to high blood pressure. So these are known as hypertension mediated organ damage. If none of these is present, none of these things are present, so in that condition we will go initially for lifestyle changes like low salt intake, high potassium intake, exercise, quit smoking. So these are the things in lifestyle modifications. So only lifestyle modification. And if after 1 to 3 months BP is not controlled, then we add the drugs. While if any one of these is present, any one of these, CAD, CKD, diabetes or hypertension mediated organ damage, straight away go for lifestyle modifications and drugs. While if grade 2 hypertension is there, that is BP of more than 160 by 100, straight away go for lifestyle modifications and drugs. So this is a simplified protocol for managing a case of hypertension. While you have to supplement this with the pharmacology, so different types of drugs, their side effects, mechanism of action. Next group of vascular disease, a more important, that is ischemic heart disease or coronary artery disease. So in those conditions, maximum questions which are asked are related to the treatment or management. So let's see those coronary artery disease. Acute coronary syndromes. So acute coronary syndrome is what to keep the target blood pressure. Target blood pressure when there is no comorbid condition, 140 to 90, below 140 to 90, and if comorbid conditions are there, 130/80 is the target blood pressure. All right. So acute coronary syndrome, identify this coronary syndrome. Patient has chest pain. Patient has ST depression on the ECG. Troponin levels are normal. This is a case of unstable angina. While troponin levels are high, elevated, this is non-escalation MI. Indeed, more and more questions are now being asked on non-escalation MI. These syndrome, they need only conservative treatment. In most of the cases, conservative treatment is given. Angiography, angioplasty is done in few cases. So these are the treatment option for conservative treatment or mainstay of treatment for case of unstable angina and non-escalation MI. Treatment of these two acute coronary syndrome is same, exactly same. What is that? Double antiplatelet treatment, DAT, double antiplatelet treatment, aspirin plus clopidogrel. Low molecular weight heparin, it prevents the size of the thrombus. Beta blocker, decrease the cardiac demand. Nitrate, increase the blood flow. Increase the blood flow. So this is the mainstay of treatment. Now, what are the indications of angioplasty or PCI procedure? What is DAT? DAT is double antiplatelet therapy. Double antiplatelet therapy. Now, PCI in unstable angina, non-escalation MI, if patient is hemodynamically unstable, patient has ventricular tachycardia, and patient has signs and symptoms of heart failure, any one of them, patient should undergo PCI within 2 hours. That PCI is known as immediate PCI. Life-threatening conditions are there. So within 2 hours it should be done. So these are the indications. Now the next one, there are new ST changes. New ST changes is key thrombus is moving here and there. It has not yet stabilized. Troponin levels are showing increasing trend. So that means we have to go for a PCI because thrombus is not yet stable. That is causing new changes in the ECG. So we will go for an early PCI. Early PCI is within 24 hours. It should be done within 24 hours. While if patient has diabetes, multivessel disease, patient has prior bypass or prior PCI procedure, so in these, before discharging the patient, we want to see angiography. What is the status of the blood vessel? What is the status of the graft? What is the status of stent? So before discharge, we will do delayed PCI. So the delayed PCI is done 24 to 72 hours. So we'll conservatively manage the patient, and after 2-3 days, when we are discharging the patient, do check angiography just to see the coronary anatomies. So this is the indication of delayed. Now, coming to the ST elevation is present in the ECG. ST elevation is there in the ECG. Troponin levels are normal. So that means it is not a case of any myocardial infarction. This is a case of Prinzmetal angina. So this is Prinzmetal angina. The Prinzmetal angina is due to vasospastic process. So we give vasodilator agents. So these agents are emergency. We give nitrate, and we shift the patient to maintenance therapy with calcium channel blocker or vasodilator agents. So this is the treatment of the Prinzmetal angina. Prinzmetal angina. So troponin T or I, it does not matter. It can be a troponin T or it can be troponin I. So any of these, if they are normal, so it is angina, not myocardial infarction. Yes. While ECG ST elevation is present, troponin levels are elevated. So this is a case of ST elevation MI. So this is a case of ST elevation MI. ST elevation MI, mainstay of treatment is through PCI. We remove the thrombus and put stent in its place. We put a stent in its place. So these are some of the time intervals which are asked from you. Very importantly, so if the time interval which is asked from you is door to balloon time, understand the meaning. Door means patient has come in the emergency. So time of the entry of the patient in the emergency department of hospital. So from that time, when patient has entered the emergency, PCI should be done by the doctor within 90 minutes. So this is the time given to the doctor. Within 90 minutes, PCI should be completed, known as door to balloon time, from the entry of the patient till the balloon or stenting. While after the symptom onset, so know the difference between the door to balloon time and symptom onset for PCI, because if the thrombus is old and we remove that thrombus, reperfusion arrhythmias can take place. So that is known as symptom onset for PCI. It should be within 24 hours. PCI should be done. If patient come to you after 24 hours, even in a PCI hospital, conservative treatment is done. Do not go for opening of the thrombus. Reperfusion injuries will take place. While door to needle time, door to needle time is for those center where PCI is not available and we can't shift the patient to the higher center in a timely manner. So when we are planning for thrombolytic therapy, so door to needle time, meaning of the door to needle time is entry in the hospital to needle means start of the infusion. That is the needle time. So that will be less than 30 minutes. That is less than 30 minutes. While symptom onset for thrombolysis, ki how old is the thrombus? So that is determined from the symptom onset. So that should be less than 12 hours, because after 12 hours, thrombus will be organized, and in that penetration of thrombolytic agent will be less. So therefore it should be done within 12 hours. Now the decision of shifting the patient to a higher center, if PCI is done in a timely manner, so that time period is shifting. So shifting to the PCI center should be done if the delay in PCI. What is the meaning of delay in PCI? Delay in PCI is travel time on the road. And PCI procedure time. Both are added. So if that time period is less than 120 minutes, then we will shift the patient. symptom onset to PCI means, symptom onset means ki from the symptom of the patient within 24 hour, if patient come to the hospital, then it should be done. If patient is presenting after 24 hour of the symptom, PCI is not to be done. Patient is eligible for PCI. Now, so on symptom onset is ki it is the chest pain which has started. So within 24 hour, if patient come to the hospital, because patient waste their time at home. So if patient come within 24 hour, patient is eligible for PCI. Eligible for PCI. The PCI time, delay in the PCI. Suppose if patient comes in a small hospital, and we are planning to transfer to a large hospital, there will be a delay in shifting on the road, traffic, delay in the road. Patient enter into the operation theatre where cardiologist will do the PCI, and PCI procedure take 25 minutes. So we add travel time plus PCI procedure time. If that combined time is less than 120 minutes, that we expect, that is a expected delay. So if that is a less than 120 minutes, so we will shift the patient to a larger hospital. If that delay time in shifting is more than 120 minutes, then we will thrombolize the patient in a small hospital. Delay between balloon and door to needle time and symptom, that is very simple. If a patient has come in the hospital, so within 30 minutes when patient enter the hospital, doctor should start thrombolysis, and symptom onset is from home. What is the duration of the symptom onset? All right. He has already been shifted to a large hospital. Is really practical in India? Yes, it is practical in India. Why not? All right. So now coming to your answer. So when there are many choices, there is weakness. So if you are given many choices, you will do PG, PLAB, USMLE, civil services, there will be weakness. You will not be able to succeed. But if there is only one choice, there is strength, there is success. So make no plan B. This is all plan A. All right. So identify the picture. Name this person. Name this person. All right. So this is this person. All of you know. Yes. Okay. Now tell me who is this. Yes. Who is this? Let me see who will give me the correct answer. So reading the Australian player name give you a pain. Yes, you will have a pain on reading the player name. Okay, Brad Hawks. So what happens during the initial years, Brad Hawks bowled the Sachin Tendulkar out in the first match. And he went to Sachin Tendulkar for autograph. Sachin Tendulkar gave the autograph. This day will never come in your life. But after writing that statement, Sachin Tendulkar was very scared. He has written, but what if Brad Hawks bowled him out next time? So his reputation will be at stake. Now, after that match, they played for at least 5-6 years more together, opponents, and you will be guessing कि in the end who won, who was the success, who has got the success. Sachin Tendulkar has only one choice, कि he will not be bowled out by the Brad Hawks, while Brad Hawks has multiple choices, कि in this match if I'm not able to take the wicket of Tendulkar, then maybe in next match or in next subsequent match. So multiple choices, only one choice. So prepare yourself like Tendulkar, and from that match onward, Sachin Tendulkar was not bowled out by Brad Hawks. Such was the preparation of Sachin Tendulkar. He prepared so much that he kept his words. He has written the words. This day will never came in your life. So this will be the level of your preparation. Your preparation means it should be so strong that in the exam, out of the 4 choices given to you, multiple options, you will see only one option, only one correct option. For example, prepare yourself so much. Astra Shastra taiyar kar lo. So even if there are 300 people in front of you, your machine guns should be so strong, made from Atmanirbhar Bharat. You will be like animal. So win against all the odds and have only one choice. So you will get success in any path which you will choose. So this is the moral of the story. Do not have multiple options. Have only one strong choice in your life. So now let's come to the next topic. So the next topic is heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction, CHF patient. So CHF patient, first line drugs we will give to the patient. So first line drugs which are given here are ACE inhibitors, beta blockers. So remember, beta blockers, they are only 3 drugs which are used for heart failure with reduced ejection fraction. So these drugs are metoprolol, bisoprolol and carvedilol. So only 3 agents. Examiner might give you propranolol, but that will not be the answer for the correct option. So beta blocker, metoprolol, extended release, bisoprolol and carvedilol. While aldosterone levels are high, so give anti-aldosterone medications here. So you can use any of these agents. While SGLT inhibitors, so SGLT inhibitors, sodium glucose cotransporter 2 inhibitors, they will be given, and they can be given even without diabetes. Remember, the role of these agents is in diabetes. So even without diabetes, they can be given. So these are the 4 line agents which are given for the management of heart failure with reduced ejection fraction. Now, after 3 months, if the ejection fraction remains less than 35%, so patient have high risk of sudden cardiac death. Patient can die. Whenever ejection fraction goes down, arrhythmias occur and that cause sudden cardiac death. So in all the patients, if ejection fraction is less than 35% in spite of maximum doses, so you give one, plan for a procedure, a device. That device will sense the arrhythmia and deliver the DC shock immediately. So that prevents sudden cardiac death. That device is ICD device. So implantable cardioverter defibrillator device, given in all the patients. Why? If left ventricle become enlarged, it will stretch, left bundle will be damaged. So what happens? Both the ventricles, this is left, this is right. If left ventricle stretch, it stretch the left bundle branch block will occur. So what will happen? Right ventricle will depolarize early, followed by left. Normally, both the ventricle depolarize at the same time. So what we should do in that condition? We make a pacemaker, we will put a pacemaker which will depolarize both the ventricle at the same time. So we do synchronization of the ventricle depolarization. we will make both the ventricle depolarize simultaneously. That will improve the cardiac output. That will improve the cardiac output. So that treatment is cardiac resynchronization therapy. That is just a pacemaker. So if the patient has wide QRS, that is left bundle branch block is there, left ventricle will be depolarizing late. So go for CRT, cardiac resynchronization therapy. Cardiac resynchronization therapy that will be given. So both the ventricles are not getting depolarized because left bundle branch block is there. So we let both the ventricle depolarize at the same time by putting the pacemaker in the ventricles. So that pacemaker will let both the ventricle simultaneous synchronized manner depolarize, known as cardiac resynchronization therapy. So this is the treatment which is given. CRT full ICD full form, implantable cardioverter defibrillator device. Implantable cardioverter defibrillator device. All right. Now side effect of these medications. So side effect is asked and name that medication. So the side effect is if a patient has got bigeminy rhythm. These are very important question. Side effect of the heart failure medication. So if there is bigeminy rhythm, hockey stick sign on the ECG is being seen. So the answer for this question is this is digoxin. This is digoxin. Yes. Now the next one, patient has dry cough, angioedema is present. So there is a space below that topic, so you can utilize that space for these important side effect of the medications. So important side effect is bigeminy rhythm, hockey stick sign in the ECG, drug name is digoxin. Why? Dry cough, angioedema, answer ACE inhibitor. Yes, it is ACE inhibitors. Male patient has got gynecomastia. Spironolactone is the answer. So it will be due to spironolactone. While if patient has got gangrene, Fournier gangrene, so the side effect, this is the side effect by the medication which has very high chances of genitourinary infections. So that drug which cause Fournier gangrene, it is SGLT inhibitors. So SGLT inhibitor have this side effect. So these are some characteristic unique side effect of the heart failure medications. Now moving on to the innermost layer, that is the conduction system. So in the conduction system are the arrhythmia section. So whenever a patient of arrhythmia comes to you, so first especially the tachycardia. So in the tachycardia, just look at the QRS. If the QRS is wide, look at the heart rate. If the heart rate is 100 to 250, this is a case of ventricle tachycardia. If heart rate is more than 250, that is ventricle flutter. So if the tachycardia is present like this, so these are the QRS complex which are seen, and these are all same shape and size. This is a case of a monomorphic ventricle tachycardia. Monomorphic, same morphology. While if the morphologies are different, these are all QRS complexes, but they have different morphology. Some are height is more, some QRS height is less. So this is a case of a polymorphic ventricle tachycardia. So heart rate should be 100 to 250. While if the heart rate is more than 250, it is a case of ventricle flutter. So in that condition, we will get to see QRS complexes which are coming very fast, and the distance between the QRS complex will be less than 6 millimeters. 6 millimeters will make the rate more than 250. So this is a classical diagram of ventricle flutter. While QRS complex is normal and P wave is seen in the ECG. So identify, is each P followed by QRS? If your answer is yes, each P is followed by QRS, this can be either a sinus tachycardia or atrial tachycardia. So here in this example, look at the P wave. This is the P wave followed by QRS, P wave followed by QRS, P wave followed by QRS. But these are different morphologies of the P wave. So this is most likely a case of atrial tachycardia. In atrial tachycardia, P waves are different morphologies, they are abnormal. So this is each P followed by QRS. While in the next diagram, if each P is not followed by QRS, you can see 3 P waves are there, and after the 3 P wave, 1 QRS is coming. And these P wave are just like sawtooth appearance. Sawtooth appearance. So this is a atrial flutter. This is a case of atrial flutter. Sawtooth appearance. Now, this is one of the most frequently given. 90% of the cases in the exam come from this flow chart. QRS is normal, P wave is absent. P wave is absent. So, if heart rate is regular, like here you can see the heart rate is regular, RR interval is regular. So this is a case of PSVT. While here, heart rate is irregular and P wave is not, definitive P wave is not seen. This is a case of atrial fibrillation. Yes, for PSVT, we give adenosine drug of choice. For AF, we give drug of choice beta blocker. We give beta blocker. Yes. Now, innermost layer, besides the conduction system, we have rheumatic fever, valvular heart disease, and infective endocarditis. So, rheumatic fever, these are the traditional criteria, Jones criteria. So we should have, for proving a diagnosis of rheumatic fever, 1 major criteria plus 2 minor or 2 major criteria. This is no change in the criteria. While the most common major criteria is the involvement of joints. Most common cause of death, carditis. Most common valve involved, mitral valve. And most common valvular lesion out of MS and MR, answer MR. For rheumatic fever, it is regurgitation. Least common valve affected, pulmonary valve. Now, there is one characteristic murmur. Say this is a mitral valve, inflamed mitral valve. From the atria, blood go to the ventricle in mid diastole maximally. So during the mid diastole, which is also known as a passive filling phase, blood flow over inflamed mitral valve. Blood will flow over inflamed mitral valve. It create a murmur. Turbulence is there in the mid diastole. So this murmur is mid diastolic murmur due to turbulence of blood flow over inflamed mitral valve. This murmur is known as popularly Carey-Coombs murmur. Yes, it is a Carey-Coombs murmur. Most common extra-articular manifestation, fever. In a minor criteria. Otherwise, major criteria will be carditis. Now, the duration of prophylaxis for primary prophylaxis, it is a single dose of benzathine penicillin. Primary prophylaxis, benzathine penicillin is given single dose. Primary prophylaxis means pharyngitis has occurred, but rheumatic fever has not yet occurred. So we have to prevent the conversion to the rheumatic fever. So this is known as a primary prophylaxis. Single dose is sufficient. While if it is a secondary prophylaxis, drug of choice is benzathine penicillin only, and the duration will depend on carditis. If there is no carditis, 5 years or till the patient achieves 21 years of age. 21 years of age. and do a minute correction here. Just remove no carditis here. Just remove the word no. That means carditis positive. Just do a minor correction. Remove no. So if a patient has carditis, duration of the prophylaxis will be 10 years or till patient age is 21 year of age, whichever is longer duration, whichever is a longer duration. Yes, and for rheumatic heart disease, ideally in India, the duration of the prophylaxis is lifelong. Duration is lifelong. So this is an important slide. Many questions come on from this slide. Secondary prophylaxis. Secondary means rheumatic fever has occurred. Now you have to prevent the recurrent episode of rheumatic fevers. Recurrent episode of rheumatic fever. Primary prophylaxis duration, it is single dose. Primary prophylaxis is you have to just treat the pharyngitis. That will be treated with a single dose of benzathine penicillin. Alright, previous slide. This is a previous slide. Yes, within 9 days of pharyngitis, benzathine penicillin should be given within 9 days and a single dose is sufficient. Now this is a stat diagram. You can see in this diagram there are circular red colored lesions. They are present over the trunk. These are erythema marginatum. One of the frequently given diagram based question on rheumatic fever. Skin lesion, erythema is red, margin is marginatum. So it is erythema marginatum. Yes, EM. Now coming to the valvular heart disease. So the valvular heart disease, if it is a left-sided valvular heart disease, common symptom will be dyspnea. And if it is a right-sided valvular heart disease, the symptom will be swelling. So depending on the murmur, we can identify the cause of these murmurs. So pansystolic murmur. Patient has dyspnea. This is a left-sided murmur. So with the help of some more information, patient has rheumatic heart disease. Patient has most commonly apex is displaced. So left ventricle is dilated. Apex will be displaced here. Pansystolic murmur is present. So identify in the box what is the answer of this murmur. This question came in the NEET PG 23. Pansystolic murmur, the most likely valvular defect will be. So this is a left side defect because there is dyspnea. Answer is mitral regurgitation. So this is MR. Yes, mitral regurgitation. While the next one, mid-diastolic murmur. Patient has rheumatic heart disease, patient has hemoptysis, patient has loud S1. Loud S1 has only two cause, MS and TS. So the answer here will be mitral stenosis. The third one, early diastolic murmur is there. Patient has a nocturnal angina, nighttime angina will be there, and bis variance pulse is present. Left side murmur, early diastolic, only one answer, aortic regurgitation. This is a case of AR. While the last one, ejection systolic murmur, so there is only one answer which is there. It will be a case of aortic stenosis. Ejection case is present in aortic stenosis. So this is how with minimum information you have to make a complete diagnosis. And for any valvular heart disease, essential thing is murmur. You have to see the murmur. And remember, whatever are the left-sided valvular heart disease, same valvular heart disease of right side will produce the same type of murmur. Exactly. And what will be the symptom in those conditions? Symptoms in those conditions will be swelling. Sign will be congestive hepatomegaly. That will be the sign. So let's identify the right-sided murmurs. So patient has swelling, pansystolic murmur is present. Underlying cause was core pulmonale, right ventricle dilatation was the underlying cause. Pulsatile liver is seen. So obviously pansystolic murmur is seen in MR and TR, and this is a right-sided murmur. So this is TR. Mid diastolic murmur of right side, tricuspid stenosis. Early diastolic murmur of right side, same valvular lesion but on the right side, pulmonary regurgitation. Ejection systolic murmur, congenital is the cause, answer PS. So this is how you can just translate what are the right sided and left sided murmurs or valvular heart disease. Now the next set of the question will be asked what is the treatment or how to approach a case of valvular heart disease. So remember, majority of the treatment are asked from severe valvular lesions, and the treatment is usually surgery. So if a patient comes to you with a severe valvular lesion with symptoms, symptomatic, so answer is surgery. Answer will be surgery. While if a patient has severe but asymptomatic, severe asymptomatic for the valvular heart disease, now there will be atrial fibrillation. If there is a atrial fibrillation with asymptomatic patient, in the asymptomatic patient, so AF in MS, asymptomatic patient, severe valvular heart disease, go for surgery. While if atrial fibrillation is present or ejection fraction is less than 60% in MR, go for surgery. Severe patient, severe valvular disease, asymptomatic patient, but ejection fraction is less than 50% in MS, in AS or AR, surgery. So no details, no complicated flowcharts are needed for you at this level. You should have a broad idea what should be the treatment decision and what are the surgery of choice. Surgery of choice for a case of mitral stenosis is balloon valvotomy. Percutaneous catheter is put in the mitral valve. Percutaneous mitral balloon dilatation, balloon valvotomy, PMVV. Percutaneous mitral valve balloon valvotomy. MR, repair the valve. AS, aortic valve replacement. AR, aortic valve replacement. So in MS, balloon valvotomy. In MR, valve repair. In AS and AR, it will be replace the valve. Replace the valve. Yes, aortic valve replacement. Now the last topic is infective endocarditis, and there were many requests from the students कि Duke's criteria has been revised. So what you should do, you should just understand and listen the revision in the Duke's criteria, while PDF will be uploaded to you. No need to write it. Just understand what has been changed in the Duke's criteria. So the infective endocarditis will discuss new Duke's criteria, but before that, some of the important questions, that is the most common predisposing factor for infective endocarditis. So most common predisposing factor is mitral regurgitation, MR. Most common congenital heart disease leading to infective endocarditis is VSD. Most common cyanotic congenital heart disease, tetralogy of Fallot. most common non-cardiovascular risk for infective endocarditis, IV drug abuser, community acquired, and hospital acquired. These are the one-liner questions, and they have not changed. The answer have not changed. They are same. They are same. So most common non-cardiovascular risk for infective endocarditis, IV drug abuse, community acquired is Streptococcus viridans, and hospital acquired is Staph aureus organism. Yes. Now for prosthetic valve, within 1 year, maximum risk of prosthetic valve endocarditis occur, and that will be from skin. That will be from skin. So answer for both the condition is CONS, cons, coagulase negative staph. After 1 year, it is from community. Streptococcus viridans from the community. While most common infective endocarditis in IV drug abuse, right-sided is the most common valve affect, tricuspid valve. So it is Staph aureus. Surprisingly, it is Staph aureus. Staph aureus. While left-sided, it is enterococci. It is enterococci. So overall, IV drug abuse, Staph aureus, right-sided Staph aureus, left-sided it will be enterococci. Yes. Now the Duke's criteria. So just listen in the class. They will not ask you much details of those revisions. They will just ask you whether that is a criteria or not. So till now we have done key major criteria were microbiological evidence and echocardiographic evidence of infective endocarditis. Now they have added a third major criteria, surgical. So during the surgery, if surgeons see vegetation, so that is considered as a major criteria. While in the minor criteria, you can recall that 5 minor criteria were there: predisposing factor, fever, vascular phenomena, immune phenomena, and microbiological evidence not satisfying the major criteria. Not satisfying the major criteria. So 2 are added here. These are imaging evidence of infective endocarditis on PET scan and clinically auscultation of a new regurgitant murmur. So red one I have highlighted. So my expectation will be they will just ask what are the criteria, minor or major. Details they will not ask you. They will not ask you. And one more important revision which has taken place, and that revision is blood cultures removed from the requirement for timing and separation of the blood culture. They should be separated by 12 hours, they will be separated by 1 hour. That has been removed. That was making the criteria more complicated. So this slide is sufficient for the new Duke's criteria, and if you want to know what are those revisions details, it will be given to you in the PDF format. So we move to the prophylaxis. So before the prophylaxis, the number of combinations are same, no change. There should be 2 major criteria which you have done earlier, or 1 major plus 3 minor criteria, or 5 minor criteria. 5 minor criteria. So this will make a case of definitive infective endocarditis. While prophylaxis, now this is an important one. The patient who is going for a dental procedure, so before the dental procedure you should give prophylaxis. You should give prophylaxis in high risk patients. In the high risk patients. So this prophylaxis is given before dental procedures. before the dental procedure, and dental procedures in the patients with prosthetic heart valves. This will be asked. This risk factor will be asked. The patient who has got a prosthetic heart valve, or patient who have got some left ventricle pump, artificial pump, which pump the blood from the left ventricle in CHF patients. So this is known as left ventricle assist devices. Left ventricle assist devices. While prior endocarditis which has happened, so this could be a potential question कि high risk patient for developing endocarditis is the patient who has got a prior episode. So even if you are not able to remember all the risk factor, my advice is just remember, or maybe you can do star mark. The first one, prosthetic heart valves. Number third, prior infective endocarditis. In those patients, prophylaxis is needed before the dental procedure. A patient who has got a cyanotic heart disease, unrepaired, or repair has been done within 6 months, or post-transplant valvulopathy. So these are additional criteria for a high-risk patient. But most important, prior infective endocarditis and prosthetic heart valves. Prosthetic heart valves. Now, what are the antibiotics to be given? The antibiotic to be given if patient is allergic to penicillin. If patient is allergic to penicillin. So there are two scenarios. There is no allergy to the penicillin and there is allergy to the penicillin. Patient is able to take orally, because sometimes because of the dental issue patient might not be able to take orally. So we can give IV as well. So oral amoxicillin, IV ampicillin. While if a patient is allergic to the penicillin, so we go for clarithromycin or azithromycin. Either of these agents will be given. And if IV has to be given, so in that case we will give cephalosporin, ceftriaxone will be given. And you will be then questioning ki if a patient is allergic to penicillin beta-lactam, should we give ceftriaxone? Answer is yes. Even if patient is allergic to penicillin, you can give ceftriaxone. Only thing where you will not give ceftriaxone is when there is a immediate hypersensitivity to penicillin. If there is no immediate hypersensitivity, then you can give ceftriaxone. And if there is a immediate hypersensitivity, IV azithromycin is available in some centers. So you can give IV azithromycin also. So these are the treatment options for the prophylaxis. So all the very best. So these were the topics, high-yielding topics of medicine which I have taken. So all the very best wishes, and work hard, revise these notes, and if there is any further doubts or questions, you can ask in the DAMS Telegram channel. So I will wind up my class here. Thank you all of you.